So, what I'm trying to say is I had so much fun yesterday that I lost my voice. And I need to learn sign language right now to be able to communicate. And what really struck me about this again is how something that is developed for people who are deaf is actually something that everybody can use. It's helpful for everyone. We should all be learning sign language in schools. I thought actually it would actually even help transcend barriers, but I also learned yesterday that sign language between Ethiopia, Tanzania, and Rwanda is very different. Maybe we can overcome that over time. Anyway, bear with me today with my voice, but it's a real pleasure to be here. I am middle-aged, graying hair, with a beard and glasses. I'm in a suit and a pink shirt and tie. Really, I'm excited to be here. I wish I had Peter's voice, actually. That would help today. But I think this session that's opening the second day is unique, I think, for Inclusive Africa in bringing so many government stakeholders to the table to hear the voice of policymakers that are trying to make a difference for inclusion accessibility. We've heard a lot from innovators, from entrepreneurs, philanthropists, NGOs, organizations of people with disabilities, AT users. And this morning we'll get to hear from those sitting in positions of responsibility in government about what they're doing and their experiences in increasing access to assistive technology. So it's my pleasure to introduce the panel. I will take my notes for that part. So of course, at the far end, we have Dr. Zainab Gura, the Deputy Director General of the Ministry of Health of Kenya. Welcome. We have from the DRC, Mr. Masuga Musafiri Willy, Director, National Community-Based Rehabilitation Program at the Ministry of Health. Please wave your hands so people know who you are. Thank you. We have from Rwanda, Dr. Iradukunda Fabrice, Injuries and Disabilities Officer, Non-Communicable Disease Division, Rwanda Biomedical Center. From Senegal, we have Mr. Djibril Bey, Director, National Center for Orthopedic Equipment. And from Tanzania, we have Dr. Msafiri Kabulwa, the National Coordinator for Geriatric Health Services and Health Service for Persons with Disabilities. And last but not least, from Zambia, Dr. Misa Funjika, ophthalmologist at the Ministry of Health. A round of applause, please, for the panelists. We'll do 2 quick rounds of questions, and then I want to have a bit of time to have a discussion with the audience and hear from you. You may have questions to the esteemed panelists. Let me first start with Kenya as our host. And by the way, I should also mention that Kenya was one of the founding members of ATscale, the Global Partnership for Assistive Technology that I represent here today. They've been one of the countries leading the charge globally for access to assistive technology, and we're very grateful for their leadership role, not just in Kenya, but beyond. Dr. Gura, you've done a lot, and your government has done a lot over the past few years to develop new policies and initiatives to increase access to assistive technology. Can you maybe speak a little bit about some of the things that you've introduced?
Thank you, Pascal. First, allow me to welcome all of you, the people who are Kenyans and non-Kenyans, to this, and also to Kenya as the gracious hosts. And we are grateful to be part of this inclusive conference. The Kenyan government and the Ministry of Health in particular are focused on making sure that we achieve universal health coverage. And that means we get quality health care for Kenyans at affordable prices. And for us to achieve UHC, our rallying call is leaving no one behind. And that rallying call actually fits very well because we are saying no one should be able to get into catastrophic expenditure, that is sell your assets to be able to access healthcare. No one should miss any of the services from preventive to curative to palliative to rehabilitative services. So for that matter, it's not only leaving behind somebody in terms of accessing healthcare, but also not leaving behind any component of healthcare. And so we are approaching this comprehensively and holistically. We historically, rehabilitative services and use of AT, availability of AT is one of the things that we realized have not been worked on so much, and that has changed over the last few years. We have started putting in policy initiatives that make sure that persons with disability, differently enabled persons, actually have access not only to the AT, but also to the healthcare services they need, because all of us need healthcare services for one reason or another. Some of these policy initiatives include, first, we realized we don't even have a strategy for achieving the rehabilitative services we need and the AT that our people need. So we put in place a strategy that clearly spells out what do we need to do to be able to get to where we want to have that leaving no one behind spirit. Once that strategy was ready, we also looked at how do we classify or how do we categorize the disabilities that people have. When someone comes to seek healthcare services, for you to get the right AT, you have to have a prescription, categorization. We didn't have the tools for that. So we put in place guidelines to categorize the disabilities in different forms. We sensitized our people to be able to understand. We developed group committees to be able to do this. And very importantly, we decentralized that activity from being centered at the headquarters in Afya House, that is the Ministry of Health headquarters, to the counties where it will be nearer to the people that actually needs it. So that at every county they have a committee, they have a health facility that is able to do this, so that the right AT is actually prescribed for the persons that need it. In addition, we also looked at, we realized that we cannot be able to do this alone as a ministry. It is cross-cutting. We need the stakeholders. We looked at how are we going to coordinate with nationwide, government-wide, and partners, so that it is a whole of a nation approach rather than just a government approach. So that is actually critical to bring together everybody to the table. I think if given time, I'll talk about that a little bit later. Allow me to just point out two more. Data is critical. Information is power. And we looked at how are the ways for us to get the actual data that we need to be able to provide the services we need. And several approaches were made. One, we included disability questions in the census. Secondly, we developed the tools that we need the Ministry of Health so that in the health sector itself we get the right data. 3, we developed survey tools to rapidly assess what are the AT needs in the country so that we understand that. Then from the point of information, we can be able to develop programs that help us make the decisions that are appropriate. Finally, in government of Kenya, there's something we call disability mainstreaming. It is a performance indicator for all the government ministries. And there are specific things that is followed up, and performances of our cabinet secretaries that are the ministers are actually this is one of the main indicators, and this is mainstreamed government-wide to make sure that we are looking at these indicators actively and consciously. It's not just as a by the way. Allow me to stop you there. Thank you.
Thank you very much, Dr. Gura. This is a lot of very, very good insights, and a strategy, multi-stakeholders, what they're doing with the health insurance, the data, so many important points that really all countries should be looking into. Let me turn now to Senegal, who's also embarked on a similar journey. Maybe, Mr. Bay, you can speak a little bit about the National Steering Committee that you've put together to help drive these efforts, le Comité de Pilotage, and maybe say a few words about how that's working and how you plan to use that to help drive the strategy.
Merci Pascal. Permettez-moi de saluer tout le peuple kényan pour l'accueil chaleureux de toutes les délégations africaines et des partenaires qui nous viennent d'ailleurs. Je voudrais juste en fait vous me permettrez de remercier le partenaire ATscale qui a beaucoup fait pour le Sénégal. Au-delà des aspects financiers, le Sénégal a eu quand même le soutien, l'appui de l'Organisation mondiale de la santé et du partenaire ATscale pour stimuler les politiques en matière de réadaptation fonctionnelle et d'améliorer l'accessibilité aux technologies d'assistance. Ce projet nous a permis quand même effectivement de définir des politiques. Il y avait une absence, il y a la volonté politique y est, mais les urgences étant à tous les niveaux du système de santé, la lutte contre les maladies non transmissibles, la lutte contre les maladies transmissibles, qui captent presque l'ensemble des financements, à un moment donné, laisser en rade des choses extrêmement importantes et prioritaires qui sont le financement de la réadaptation et de l'accessibilité aux technologies d'assistance. Aujourd'hui, grâce à ce projet, les autorités, et grâce au plaidoyer que nous avons porté, les choses commencent à bouger. Donc c'est dans ce cadre que nous remercions énormément le partenaire ATscale. Aujourd'hui, nous avons connu des lacunes et nous continuons de connaître ces lacunes-là. Mais des politiques, la bonne nouvelle est qu'il y a des politiques qui sont en train d'être mises en œuvre. Par exemple, dans le cadre des lacunes, le Sénégal nous avons une absence de coordination au niveau national. Il était prévu de mettre en place une haute autorité chargée de l'handicap. Ceci tarde à se mettre en œuvre, mais grâce à ce projet, nous avons mis en place un comité multisectoriel. Parce que nous comprenons que ces questions sont transversales. C'est plusieurs ministères qui interviennent. Donc ce comité regroupe l'ensemble des parties prenantes et nous permet aujourd'hui de mettre en place, nous avons aussi mis en place un comité de pilotage, puisque nous avons défini des stratégies de la réadaptation fonctionnelle, de la réinsertion sociale, entre autres, qui vont tous tirer l'accès aux technologies d'assistance. Pour mettre en œuvre ces politiques, c'est le comité multisectoriel qui définit les stratégies qui évoluent sur le plan national, mais nous avons mis au niveau des régions des comités régionaux qui seront dirigés par l'exécutif régional avec l'ensemble des acteurs pour qu'au niveau régional, la spécificité de chaque région soit prise en compte. Mais au niveau supra, nous avons un comité pilotage qui est plus opérationnel, chargé donc de mettre en œuvre l'ensemble de ces projets et de corriger et d'évaluer. Maintenant, pour terminer, l'expérience que nous avons pu apprendre à cela, c'est récemment nous avons tenu une réunion du comité de pilotage qui s'est déroulée pendant 4 heures de temps, mais nous avons, pour être plus opérationnel, mis en place un comité technique restreint qui regroupe les directions chargées des infrastructures sanitaires et équipements, qui regroupe toutes les directions, la direction chargée de la protection sociale, qui regroupe la direction générale des établissements, qui est dépositaire de l'offre de soins. Une chose est de porter la protection sociale, qui est le financement de la demande. Une autre chose est de prodiguer des soins de qualité, c'est-à-dire promouvoir des technologies d'assistance accessibles, abordables et accessibles à tout le monde. Voilà ce que le Sénégal est en train d'initier grâce quand même à nos partenaires financiers.
Thank you very much. Thank you very much for that description. And as you can hear, the importance of having national coordination committees that bring together different ministries, different stakeholders to drive this agenda and to help also with the advocacy that's needed to ensure that the right financing is available. Thank you for that example. Let's turn to another country now, the DRC, the Democratic Republic of Congo. You've recently made some progress in defining an assistive product list, so an essential list of key assistive technologies that the country should have. Can you speak a little bit about that and how that is impacting the way services are provided?
Merci beaucoup, Pascal. Je tiens d'abord à dire un grand merci aux organisateurs de cette conférence, qui est une opportunité pour nous très capitale. En ce qui concerne mon pays, par rapport à l'accès aux produits, il se pose de sérieux problèmes parce qu'il n'y a pas un système d'approvisionnement en produits d'aide, de technologies d'assistance qui existait. Et donc, on ne disposait pas d'une quantification en besoin. Malgré cela, chaque année, chaque 2 ans, les pays disposent d'une liste de médicaments essentiels. Et cette liste de médicaments essentiels et produits de santé qui obtient l'exemption des taxes du gouvernement. Et pour ça, il a été question pour nous de nous référer à la liste de 50 produits de l'OMS pour arriver à prioriser nos produits d'assistance, des technologies d'assistance dans les pays. Et la première des choses qu'on a fait, c'était d'inviter toutes les catégories des usagers, des personnes handicapées, pour leur présenter la liste des produits, des 50 produits de l'OMS et les amener à pouvoir identifier leurs propres priorités. Et à l'issue de cette activité qu'on a fait avec toutes les catégories de personnes handicapées, nous avons invité les experts pour se joindre à nous afin de développer cette liste prioritaire qui, par une méthodologie de manière scientifique, nous sommes arrivés à dégager 32 sur 50 produits de l'OMS. Et donc, les pays disposent aujourd'hui de cette liste, et cette liste qui intègre la liste des médicaments essentiels, et donc qui aura accès à des exemptions et qui permettra à ce que les produits d'assistance soient disponibles dans les pays. Et donc voilà un peu notre démarche qu'on a mis en place pour arriver à définir cette liste. Merci.
Thank you. And as you've heard, another great example of what can be done, bringing together the different stakeholders, and in this case, the actual AT users from all domains to help prioritize which products should be on that list and then can be more available. Every country should be doing this, and many are already working on this on the continent. Thank you for that great example. Tanzania has been doing a lot with regards to universal healthcare. And you've really made a lot of progress on universal health coverage. And I know that AT is now being integrated into universal health coverage. Can you speak a little bit about how that has happened and where things stand?
Thank you, Moderator. I'm Safili Kaburwa, working with the Ministry of Health Tanzania. And today I'm wearing the black shoes, the clay pants with the black coats. Unfortunately, as long as I'm blindness, I'm not aware whether I'm wearing a white shirt, but it's having some blue stripes with white and with refractive wear because I'm short-sighted. Tanzania, as other countries, is striving in achieving universal health coverage. And some of the services we are doing better, but some of them we are not doing better, like rehabilitation. And with that, we embarked on conducting situational assessments on rehabilitation in the year 2019 to 2020, which later was followed by formulating a rehabilitation strategic plan, which was launched in the year 2021. And within that strategic plan, the number of areas, including the human resource and assistive technology. Taking into consideration that the human resource, I don't know in the other countries, but in Tanzania, in the area of health, they are inadequate. And when you compare in different services, it's even worse in the area of the rehabilitation. Majority of them that are currently present are the physiotherapists and the occupational therapists. And while the sign language, we are only having 3, saving the population of 61 million. With that situation, now the Ministry of Health in collaboration with other partners, including the ATscale and the WHO, we now embarked on training the non-rehab staff who are saving the majority of the population who uses the primary health care facilities. That is the council hospitals, the district hospitals, and the dispensaries. And with that, we trained the clinicians, nurses, but also the the home-based care, but who also call them the community health worker. And for this moment, I'll talk a little bit about the community health workers. And in that program, we chose one region that has been doing well in the provision of the age-friendly services. So wanted to use that because also I've been aware on how to take care of the older person. And in that region, we sampled 2 districts, and then those 2 districts also we sampled 31 health facilities, which were composed of 2 district hospitals, 10 health centers, and about 19 dispensaries. And from those 31 health facilities, we selected 150 community health workers, and these were selected in collaboration with the subnational administrators who knows the number of those community health workers. And following the selection, they were convened in one center, and they were trained on an online module of ATscale technology that has been developed in collaboration by WHO with the ATscale. And because their level of knowledge is not that much good, they are exposed on one module within that platform, which is an introduction to assistive technology. Well enough, of those 150, they passed that module of introduction to assistive technology, which is by requirement, the pass mark is 60, and all of them they passed, so that was a good milestone. And during that implementation of that project, we had also an opportunity of having some assistive technology products that were donated to us by a church based in America, known Latter-day Saints. So after following the training, those community health workers, they have to go house after house in the area that they serve, and then identify whether a person with disability or an older person who requires an assistive product, and then they linked them to the facility that they serve. Because in Tanzania, each facility have 2 community health workers that are linked with. So they used to refer those either person with disability or the person who required the assistive products that were already dispensed.
If I can ask you to wrap up, please.
Thank you.
Thank you so much. Thank you, Doctor. Another great example of, in this case, integration, and in particular through human resources and community health workers. And that is the only way I think that we can really reach across the entire country, is if we think about integrating into existing services and systems. Thank you for that. Let's turn now to our last 2 panelists and dig in a little bit more specifically on 2 domains, hearing and vision. In Rwanda, you've been doing a lot of things across the board, but in particular, you've launched a program to scale up access to ear and hearing services and hearing aids in particular. Can you speak a little bit about that program, and in particular, maybe a particular case that struck you of the impact of it?
Yes, thank you, Pascal. If I made the presentation, we started the program. We called it Scale Up Ear and Hearing Care Services in Rwanda. In Rwanda, we called it Winsigandumva Program. Translating, it means don't leave me, I can hear. That's the translation of Winsigandumva Program. So this program is now working in 9 districts of Rwanda in different areas, in different provinces, including also the city of Kigali. Yeah. So this program started as a pilot phase, where we started in specialized deaf schools. These deaf schools, we started there because it's where the staffs who experienced in audiology and screening ear and hearing care impairment. So we started there because of the staff, infrastructure, and their staff who can communicate with the children. So after realizing the importance of this program and how children can be helped and can get the gift of sound, so we said let's scale up these services into the country and integrate into the healthcare system, starting from the community up to the level of referral health centers where we provide comprehensive services. So I have many successful stories. So we have screened more than 2,000 children. We have fitted more than 500 children. We have also treated conditions like syringing with children with earwax and also giving medication to other conditions related to ear and hearing. So, but I have this one case of a child called Beriza. She's from a rural area in the southern province called Huye district. She's 12 years old. This student was in primary school 1. She faced challenges, many challenges during her studies, during home with her parents. Her parents can beat her, can just thinking that the child is disobedient or she's negligent, but the child could not hear. Also, the teachers could punish her for something she didn't able to hear. But after hearing that this program is coming, the child was enrolled, was pre-screened, and then the child went into the health centers. They wrote her on the list of people to be screened, and we trained national champions who are national champions in ear and hearing care. They are providing services now. These champions came, screened, tested the level of hearing loss, and then fitted her. This child now, you can see that she's able to interact with her parents. They can speak and she can hear. They can converse. Now the parents, they're not beating her. Her social interactions also improved. She can now play with other kids because she can hear. She loves football, but she was not able to play football because she was not hearing other teammates. But now, with the hearing aids, she can able to hear. Her school performance also improved. She's now moving ahead. She's now in P2. She was in P1 for many years, but now her school performance improved like many other children. And also the community engagement and the community stigmatization is somehow decreasing because of these more successful stories that we have, and also working with the community of workers to improve awareness and reduce stigmatization of children with hearing impairment.
Thank you very much. Thank you very much, Fabrice, for bringing this home to a very specific example. And you can see how, and of course everybody in this room knows this already, but how life-changing assistive technology is, and the power of demonstrating that also to fight against stigma and raise awareness. So thank you for that. Last but not least, let me turn to Zambia, who's made great strides on scaling up vision services and the provision of eye care and also eyeglasses across the country, and particularly perhaps in harder to reach areas as well. So maybe you can say a few words about Zambia's experience in that regard.
Thank you so much, Pascal, and we are happy to be here as Zambia to share our experiences in eye health. So provision of eye health services traditionally in Zambia were concentrated in urban areas and towns along the line of rail. But I think from 2011, the country has embarked on procedures or strategies to enhance eye health services across the country. So among some of the strategies that we've embarked on are one, development of infrastructure. As a country, we've embarked on infrastructure development, setting up of eye health services across the country in different parts of the country. As of last year, we had set up fully functional 66 eye units in 66 districts out of the 116, so that provision of eye care is where the community are to reduce travel for long distances. Another strategy that we've embarked on is human resource training. When you set up an eye unit, you need qualified, specialized staff that are able to work and diagnose the problems and ensure that there is appropriate referral for persons that need to be referred. So previously, as a country, most of our eye health staff used to be trained across abroad, most of them in East Africa, Tanzania, Kenya, and some as far as Zambia. But from 2011, we've started training locally from the level of ophthalmologists, ophthalmic nurses, ophthalmic clinical officers, optometry technologists, and this has helped improve the human resource that are able to man these eye units. We've also embarked on training primary healthcare workers. These are general nurses, general clinical officers, so that they are able to recognize eye diseases and be able to offer basic care so that we are able to reach the hard-to-reach areas. And then another strategy that has been embarked on is employment. If you are not able to recruit enough manpower to work in the rural areas, then the few that you have will be concentrated in the urban areas. So I think the government, through the Ministry of Health, has embarked on a massive recruitment drive, and this includes optometry technologists that are able to offer refractive services in the rural parts of Zambia. Provision of drugs, medicines, and consumables is also key, and this is being handled through the government medical and medical supplies agency, so that basic antibiotics for the treatment of infections are available. If you do not provide people the basic antibiotics, people then resort to non-safe medications, traditional medications, and these cause more harm than good. And then lastly, but not least, is outreach services, where we are able to move surgical teams into the rural areas to be able to provide surgeries in communities where the people stay. So we are able to offer cataract surgery, we're able to offer trichossis surgery, so that we reduce on blindness in the rural areas. I think I'll end there. Thank you.
Thank you so much. And again, a great testimony of really long-term engagement from the government to build the infrastructure and all the systems needed for comprehensive eye care. Also from a prevention perspective in this case as well. So thank you for that. I did have a second round of questions, but I'm more conscious of time, and I wanted to give the opportunity to the audience to ask questions. Many of you are from the private sector or innovators or coming from OPDs. If you have questions that you'd like to ask the panelists, please, we have a couple of minutes. Raise your hand, and the mic will come to you. Yes, the lady over there. Thank you.
Thank you, gentlemen, and hello, everybody. My name is Abigail Chepkurui. I come from M-Pesa Foundation Academy. I work there as the Access and Inclusion Coordinator. That means I am in charge of learners who have learning disabilities or learners who have other forms of challenges. So I am just here first to thank the ATscale, because my organization and school uses a lot of assistive technology. We do a program called, we don't do the Kenyan education system, we do what we call International Baccalaureate, IB. And IB is one of the most inclusive education curriculums, I think, in the world, because every examination that happens, there are learners who have excessive accommodations, one of them being assistive technology. So I just wanted to speak perhaps to our lady from the ministry. First, I was at the Kenyan curriculum education before I went into the International Baccalaureate, but I can just say, honestly, the Kenyan curriculum has not much of support and therefore accessibility to education from our learners who are able differently. I don't know whether there are any plans from the government to improve on that, because I have really seen a huge difference between the Kenyan curriculum and the International Baccalaureate. So I don't know, Madam, What plans do you have as a government? Because there are learners whose grade is way below simply because they did not get an inclusive education that involves perhaps access accommodations. Thank you.
Thank you for that question. I suspect somebody from the Ministry of Education might be better placed to respond, but nevertheless, Director General Deputy, if you want to maybe say a few words.
Thank you. I think, Pascal, you said it rightly. I know that someone from Ministry of Education will be better placed to do that. But in one of the meetings that I was part of, there are elaborate plans of how to incorporate, to make sure that education is inclusive. And not only accessibility, physical accessibility to the learner, the classrooms and the learning area, but also on the curriculum to make sure that they are covering. I think maybe since you left, there have been much discussion and much inclusion of that. But let me come back to health education, because we've also realized that when we train health workers, it was not part of their training to even learn sign language, to be able to communicate. And we also have the question of ethics if someone else is interpreting for the patient to the health worker. So we are solving that by introducing sign language, and this we're actually doing in partnership with ATscale to make sure that in KMTC we have sign language introduced as part of the curriculum of our health workers, and that is a critical step for us to remove that barrier in terms of communication. So at least that and even Ministry of Education, there's significant steps that are taken, but for specifics we can discuss.
Thank you very much. Any other question from the audience? Oh, many hands now. The gentleman here in front.
Right, good morning. My name is Cherno Sise. I'm from the Gambia. I'm visually impaired. Nominated representative for young people with disabilities at the National Youth Parliament, the Gambia, and I also work with an organization in the Gambia called Start Now. So we train visually impaired high school graduates in basic technology skills in preparation for higher education and employment. One of the panelists spoke about decentralization of medical services to the rural areas. I don't know whether it was in Zambia. Is it Zambia? Something like that. I'm not sure about the country. But my question is, how do we better decentralize medical facilities in rural settlements in some African countries like the Gambia? Per se, most of medical personnel in the Gambia in our medical sector are not disability friendly. They have limited information about how to support persons with disabilities in terms of delivery medical services. Per se, those with hard of hearing, because a lady from the Gambia some time ago was given a wrong prescription at the clinic that leads to her death because the medical personnel at the time could not able to communicate with sign languages. So I wanted to ask, what strategies do you think we can basically use in terms of training medical personnel at our medical sectors to make sure there is more of inclusive empowerment and also protection of rights and also lives as well? Thank you.
Thank you very much for that excellent question. Who among the panel would like to take it? I know that he referred to Zambia. Maybe you can say a few words about that.
Maybe I'll start and then someone else can also add. So I think scaling up of healthcare services to the rural area is not easy. So one of the strategies that can be used is integration of eye care services into the available services that are already existing at the primary healthcare facility. So I think I mentioned the training of primary healthcare workers. You may not have enough specialized staff to work in all the rural areas, but if you orient the already existing nurses, clinical officers, and doctors in what they're supposed to look for. We also, I think one of the other strategies that we've embarked on is also using teachers to be able to identify children that would have visual disability or who may have some type of visual impairment, so that at different levels, be it in the schools, be it in the clinics, we're able to pick up patients that need care and be able to treat and refer early. I think I'll end there. Thank you.
Thank you very much. Maybe somebody else in the crowd. Yes.
Thank you very much. I am Ambrose Murangira. I'm coming from Uganda. I would thank the panelists, especially those from the government, Personally, I'm a taxpayer. To be honest, I pay taxes. And the government always tax us on whatever income we do get. But now the issue goes back to access to assistive technologies. That's where the challenge is. Direct question to the government officials here. What are your plans in place to ensure that we are able to access and utilize and also affordable assistive technologies? Not necessarily related to healthcare alone, but even other services, be it education, employment, and other sectors. That's the challenge is how to finance this accessive technology. It should be very clear. Like in Uganda, I pay almost 40% in terms of tax from my salary. Pay as you earn. At the end of it all, we struggle to access assistive technologies, which is a necessity. So the government needs to think about this. Thank you.
Thank you. This is the most fundamental question, I think, that we all have before us, is how do we make affordable, accessible products available everywhere for everyone who need it? I'm not sure anybody has the silver bullet for this. We're all working around that, and everybody needs to work around that. But I'm seeing that time is up, but maybe if one of you would like to give one thought about this to respond to this question, who would like to go ahead? From Rwanda? Yes, go ahead.
Thank you so much. I think most of how we can access assistive technologies all start with developing strategies and policies, and also developing APL. Someone here talked about developing assistive technology priority list. This list, if it's available, you can advocate for insurance companies to cover most of these assistive technologies.
Thank you. I think we're going to have to wrap it up. I'm sorry for the other panelists, but thank you again so much for sharing with everyone here today what you're doing. It's a journey. We're all in this together, and everybody needs to be around the table to make this happen. So a warm round of applause for the panelists, please. Thank you very, very much.